Hi everybody, welcome to Dr. Manny's YouTube Learn Shops, and in this presentation we're going to be looking at how to conduct a health assessment. Now, what is a health assessment? And especially in respect to history taking, which I always emphasise is one of the most important tools after which we do a physical assessment. Now, a health history assessment is part of an assessment phase, which is part of the nursing process. And it's a record of the information about a person's health or their wellness. And it consists of being directed, focused, with interview questions that can be open-ended or closed. It can obtain subjective or objective data, which relates to the client's illness, functioning and life processes. Now, a health history can be diverse, but it may include information about allergies, illnesses, surgeries, immunisations, and the results of physical assessment examinations and laboratory or radiological interventions. But it can also include information about medications and their health habits, which include things like diet and whether they get exercise. Now, it's also important from a nurse's perspective that when obtaining a health history, that typically it's done simultaneously when performing a general survey, which we will discuss. Now, when it comes to assessment, when we use the nursing process, step one is the assessment. And it was in 1958 that our nursing theorist, Ida Jean Orlando, generated the nursing process. And this is a systematic problem-solving approach that's used to identify, prevent and treat actual or potential health problems. And the ultimate objective is to promote wellness. Now, in the assessment, which is the first step, you have to think critically. And this is where you collect subjective and objective data. Now, subjective data involves verbal statements from the patient or the caregiver. Objective is measurable: blood pressure, heart rate, respiratory rate, height, weight, etc. Now, the data may come from the patient directly or from primary caregivers who may or may not be in direct relation to the patient or a family member. Now, critical thinking is important, especially during assessment, and it requires things like observation, analysis, interpretation, reflecting and evaluating your findings. It also involves problem solving and decision making. So let's review again. Step one is assessment. And it's a critical component, and it's considered to be the first step in the nursing process. And ultimately, it will help generate a nursing care plan, which is a written manifestation of the nursing process. There are 5 components to it, which we will discuss in later sessions: assessment, diagnosis, planning, implementation, and evaluation. So what should be included in a nursing assessment? We said this is where the nurse collects subjective and objective information using evidence-based tools to evaluate the patient, client, victim as a whole, holistic. But a nursing assessment may include, but isn't limited to, the following: physical assessment, psychological, mental, emotional assessment, psychosocial assessment, environmental and cultural and spiritual assessment, and a safety assessment. But there could be more. What's the purpose the rationale, the objective of this health history assessment. Being repetitive, the purpose is to gather subjective, objective data from the patient, client, victim, or their family. And as I said, it includes physical, biological, mental, psychological, social, cultural, spiritual values and beliefs. And this is important so the healthcare team and the patient can work together collaboratively to create a plan that will promote health, wellness, address any acute and chronic health issues. And the health history is typically done on admission to the hospital, but it can be taken whenever and reviewed whenever additional subjective information from the patient may be helpful. What are some of the types of health history assessment? Well, there are 4 basic types. And these include the initial comprehensive assessment, sometimes referred to as the triage assessment. Then it's ongoing, or more information, which adds partial assessment. Or if there's a problem, a focused, targeted assessment. Or in the situation of a life-threatening condition, the emergency assessment. So there are 4: initial, ongoing, focused, and emergency. In the initial comprehensive assessment, the purpose is to gather subjective data from the patient or the family about their health perceptions. It includes both subjective and objective data. And this could include the general survey, vital signs, body systems, past health history, psychosocial information, family history, lifestyle, and health practices. Subjective data. What's subjective data? Well, subjective data is the patient's symptoms. So this could be pain, shortness of breath, dizziness, exhaustion, loss of appetite, body aches, sore throat, itching. They're things that the patient complains about. Then you've got objective data. This is signs. These are clinical manifestations that you can see. Their general appearance, how tall they are, how much they weigh, their level of consciousness, body temperature, heart or pulse rate, blood pressure, respiratory rate, SpO2, if they're coughing or they're vomiting. They're measurable. So, let's review. What is objective and what is subjective data? You decide. A patient says he's got a fever and has got muscle aches and nausea. He has a flushed appearance and the nurse reads a temperature of 102 degrees Fahrenheit. What is objective? What is subjective? Objective is the temperature and the flushed appearance. You can see it. You can measure it. Subjective is what the patient says. Muscle aches, nausea, experiencing a fever. Not measurable. Objective and subjective data. Again, a patient is clutching his abdomen, stomach, complaining of nausea, diarrhea and headache. The nurse observes him vomiting into the toilet. Out of this health history, what's objective? What's subjective? Objective is the nurse observing the patient vomiting into the toilet. The subjective data is the patient reports feeling nauseated, says that he's got diarrhea, and reports that he has a headache. What about this one? What's objective and what's subjective? The patient complains of shakiness, especially in her hands. When asked about her symptoms, she mentions that she has lost weight. She currently weighs 187 pounds, which is the equivalent to 85 kilograms. While she's on the scale, the nurse sees her hands shaking. What's objective? What's subjective? Well, objective is what's measurable. The patient's weight and the observation of the hands shaking. The subjective data is the patient says her hands shake occasionally, and she says she's lost weight over a period of time. Then we move on to the ongoing or partial assessment. Now, this occurs after the comprehensive assessment. So, for example, a partial assessment could be for a client with congestive heart failure who requires frequent assessment of vital signs, in particular heart rate, respiratory rate, blood pressure, SpO2, maybe even pain, chest pain. So therefore, this requires frequent observation and measurement of vital signs, skin colour, capillary refill time, heart and breath sounds. A nurse would focus on, with a congestive heart failure, on the heart rate, pulse, blood pressure, and in the event of pulmonary edema, adventitious breath sounds. Other vital signs like temperature would be performed less frequently because, again, they're not really related to congestive heart failure. Then you've got the focused assessment, and this is problem-orientated assessment. And the focused assessment doesn't replace the comprehensive. It's just a detailed nursing assessment of a specific body system related to the presenting problem the patient's complaining about. Because again, I mean, if it's related to the heart, she may be complaining of chest pain. So you wouldn't want to be doing an assessment now of her skin. You would want to be focusing on cardiovascular. So during the focused assessment, the client may complain about a specific symptom. For example, pain, chest pain. So you might use as the nurse the acronym PQRSTU. The PQRST acronym stands for provocation, quality or quantity, radiation, severity timing, and understanding of the client's perception of the problem. But there are numerous different acronyms that can be used to assess pain. Provocation, what brings it on? What were you doing when you got the pain? What makes it better? What makes it worse? Quality, quantity. How does it feel? Ache, sharp, dull, heavy, squeezing, throbbing, cramping. Where does it go to? Radiating. Does it go anywhere else in the body? Because it could go into the arm, the back, the jaw, the abdomen, the shoulder, the head. How severe is it? On a scale of 0 to 10, 0 being no pain and 10 being the worst that you've ever had in your life, how bad is it? Is it getting better, worse, or staying the same? Timing. When did it first occur? How long did it last? How often do you get it? And most important, understanding the client's perception of the problem. What do you think it means? What do you think the problem is? This is one tool that can be used to evaluate conditions. Old CARTS is another one. And the old CARTS acronym isn't that different to the PQRST-U acronym. O, onset. When did the symptom first occur? This determines whether it's acute or chronic. Location. Where does the symptom occur? And does it radiate? Duration. How long does the symptom last? Is it constant or intermittent? Character. Can you describe the symptom? Is it sharp, dull, heavy, burning, stabbing, tingling, heavy? What aggravates it? What makes it worse? What triggers it? What relieves it? What makes the symptom better? Timing. When does the symptom occur? Day, night, specific situations. Sometimes tea can be used for treatment. So how do you treat it? Do you take a medication? Do you rest? What do you do? Then you've got the S, which is the severity. How bad is the symptom? And again, you can use a numerical scale again, 0 to 10. And how does it compare to other symptoms? This is another acronym, old CARTS. Emergency treatment involves life-threatening conditions. And this could be cardiopulmonary respiratory failure arrest, polytrauma, which affects the chest, which could involve the heart, the lungs, can involve the head, spinal injury, etc. And this is where you can use the primary survey, which uses A, B, C, D, E assessment, airway, breathing, circulation, disability, which is neurological, exposure relates to temperature. And it's applicable in all clinical emergencies for immediate assessment and treatment. And this is repeated whenever you suspect the patient has become more unstable. Now, health assessment. What's the nurse's role? And look, this can relate to any healthcare provider, whether it's the nurse, the physician, the paramedic, the pharmacist, even the janitorial staff. But the nurse has got a privileged role as a respected healthcare provider. And the reason that is because we assess the patient's physical needs to prevent illness and treat health conditions in conjunction with the paramedical team. Now, to do this, nurses have to observe and monitor the patient and record relevant information to aid in the treatment of decision-making processes from the whole team. All nursing practices revolve around the nurse and the patient relationship, and it's based on therapeutic use of verbal and non-verbal communication skills. And in this relationship, the nurse learns specific physical details and has innate feelings about spirituality, culture, and psychosocial concerns. In some situations, patients disclose information to nurses not even shared with family members. It's a trusted relationship that nurses have with patients. It's also a process where the nurse gathers, sorts, analyses the patient's information and uses an evidence-based format. And this includes considering the patient's not only biological, but also social, psychological, cultural, and spiritual values and beliefs. And then the nurse documents and interprets this information, which may include identifying urgent, emergency, emergent or life-threatening conditions. And this is really important to patient safety and patient advocacy, and intervening in a timely and appropriate manner during the nursing assessment is a fundamental skill that all nurses should learn and demonstrate in the area of any of the specialities in nursing practice. Now, when it comes to the interview, there are certain phases. And the first phase is called the pre-interview phase. And this is before you even meet the patient. This is where you collect data from medical records, patient history, and review past medical illnesses, surgeries, medications, and a potential problem list. Then you've got the beginning phase, the introductory phase. And what do? Well, you be a nice person. That's what you want to do. No patient wants to be a patient, believe me. Because again, they're worried about themselves. They're worried about what can happen to them during their hospitalisation, hospital-associated infections, for example, medication errors, wrong site surgery or procedure, the list goes on. So the nurse introduces themselves by name, smiles, and states the purpose of the interview and asks the patient if they may have their consent and how they would like to be addressed. Mr., Mrs., Dr., Manny, and so forth. The nurse shakes the hands if that seems appropriate to the patient's culture and setting. It may not be. The beginning phase continues with a discussion about things that are not related, just to make the patient feel more comfortable if they seem anxious. It could be related to their family, their work, the weather, how they feel about being in hospital, and so forth. And it's important to ensure privacy by pulling the curtains, drapes, closing doors before commencing. It's about confidentiality. Then you've got what's called the working phase. And the working phase asks specific questions. And there are two types: open-ended and closed-ended. And each has a purpose, which the nurse can choose to get the response that he or she wants. Closed-ended questions are direct. They require a yes or no answer. So, for example, do you have a family history of heart disease? Has anyone in your family ever had heart disease? Yes or no? And these are important in emergencies or when a nurse needs to establish basic facts quickly. Open-ended questions, however, require the patients to explain. They're broad and they're key to understanding the symptoms, health practices, and if intervention is required. So, for example, how have you been feeling since your surgery? Have you had any concerns about your wound since the surgery? If any, what changes have you noticed to your activities of daily living since you had your surgery? These require explanation and can be considered probing as well to get more information. The interview process can close, and this is where the nurse in the interview, she summarises or he summarises by stating the two of the three most important patterns or potential problems, and also asking the patient if they'd like to mention or if there's anything else that they would like to add. And then the nurse or the healthcare provider thanks the patient, thanks the family members for taking the time to provide the information, because they don't have to. This requires consent. Now, the communication process during the interview is also important. And there are two main types of communication. Verbal, where you speak, and non-verbal, where you don't speak. And in non-verbal communication, there's an unspoken assessment, and this is where body language evaluation is reviewed. Verbal communication skills is oral communication with words that you speak and others speak out loud. The goal is to obtain as much data about the patient's health status as possible. So, for example, techniques that can be used during verbal communication are open-ended questions and closed-ended questions, which we've already mentioned. There can be listed questions, rephrasing of questions, inferring or suggesting, and providing information, which we're going to review. Open-ended questions, as we already mentioned, they're the opposite to closed-ended questions. Closed-ended questions require a simple yes or no, but open-ended questions provide the patient's perspective and give you feedback to your question in their own words. Examples could be, what was it like to have that surgery? What was the best part of being in hospital? What was the hardest part about? How did you feel about it? How did you know? What brought you to? What surprised you the most about? And in what way is that similar or different from open-ended questions? Closed-ended questions we already mentioned. These require a simple yes or no answer. No elaboration required. They just confirm facts, clarify any confusion for you as the interviewer, and then they narrow the focus. So, for example, are you feeling better today? Yes or no? Do you have chest pain? Yes or no? Was your mother a diabetic? Yes or no? Can you ambulate to the bathroom? Yes or no? Are you having a low sodium diet? Yes or no? Do you take your prescribed medication? Yes or no? May I start your physical assessment, please? Yes or no? These are closed questions. Listed questions is another way to ask. So, for example, you could then say, is the pain severe, mild, constant? Do you get it at rest? Daily, hourly, monthly, yearly, sharp, dull, burning, etc. Rephrasing questions, sometimes, as physicians do, they now ask questions in a very technical, medical manner. So therefore, the question may require rephrasing to make it simpler, really. And therefore, this just rearranges the original question for clarity for the nurse and the client to reflect on. So, for example, Mrs. S tells you the nurse that she has been feeling tired and nauseated for 2 weeks, and she's worried that she's got a terrible disease. So you could rephrase that and say, well, what's she asking, or what's she telling me? So, are you telling me that you're thinking that you've got a serious illness? Rephrasing questions. Inferring questions. Even though you don't really want to infer, because this may introduce bias, or the client, patient, family member may just accept what you're saying, but it's basically from what the patient tells you and what you observe. So, as I said, be careful not to lead the client to false answers. They may just grab at what you're saying. So, for example, during a pain assessment, Mrs. J tells you that she has really bad pain. You ask her, where is the pain? And she says, in her stomach. Well, you observe that her hand moves to the abdomen, to the right lower quadrant. And even though it's not the stomach, it's probably the appendix, but again, here, the stomach is really her way of saying abdomen. So you say it seems to be mainly on the right side of your stomach. Okay, the stomach is the client word. Abdomen is your word. So you don't change it, you just infer it. Non-verbal communication, and this is really important because non-verbal communication is equally, if not probably more important than verbal communication. Because again, the patient may, for example, say, no, I'm okay, and their facial expression doesn't say that. Or you may say to the patient here, I'm happy to be here, looking after you, and your facial expression, body language doesn't state that. Have a look at some of the images that you're looking at the screen right now. So the nurse's physical appearance, facial expression, posture, positioning, gestures, eye contact, voice, they're important components. And again, remember, everybody's culture isn't exactly the same. So it's always important to make sure that you're allowed to touch the patient before you do so. You ask for consent. Better to have that image than that image. Better to have that image because again, it's friendly. Non-verbal communication. And non-verbal communication is more important, according to the diagram that you're looking at, than verbal communication. Look at the images. 3 of them are problematic. 1 of them is not. So what are some of the sources of information that we can acquire? Now, primary data, primary is the patient. Secondary sources of data can be the patient's family, medical charts, friends, and they may not be quite as reliable, but they are still sources of data. Remember, sources of data require a reliable historian, which means they provide effective, reliable information. Biographical data is important, and this includes things like name, address, gender, date of birth, social security number, medical record number, health insurance, and so on. And it also encompasses environmental data because again, it could be related to toxic exposure, contagious diseases, high-risk areas, pollution, hazards, and allergens. For hospitalised patients, the nurse identifies the level of independence and support requiring following discharge. Because again, the patient may have safety issues at home. They're elderly, they have stairs, they could slip, fall, and so forth. And again, it could relate to their occupation as well. So then you've got what's called the chief complaint. The chief complaint is, why did they come to hospital, to the emergency department, to the clinic, to you, the community healthcare provider? And the chief complaint basically is just a brief statement in the patient's own words why she came. I couldn't breathe properly. I had pain in my chest. I couldn't go to the toilet. The chief complaint typically has got 2 elements, and they are signs and symptoms but not too many. And the time factor. How long has it been going on? So a question from the nurse or the healthcare provider could be, what's the major health concern at this time? Why are you here? How can I help you? Tell me why you came to the hospital today. What happened that brought you to the hospital today? And the nurse, the healthcare provider, records the responses in the subjective part of the documentation. These are patient quotes. So, present health history is important. And this is a description of the present illness. And this is where you ask the patient to explain what the problem is. And it focuses on onset, progression, duration, signs and symptoms, and related problems. So, what does the patient think is causing the problem? What does the patient think makes the problem worse or better? Does it affect their lifestyle? And again, as we mentioned previously, you can have common mnemonics, things like cold spa, PQRST, old carts. We didn't mention cold spa, but I'm going to mention it here. So cold spa, very, very similar to old carts. Very, very similar to PQRST. So C, character. What's the problem? Onset, when did it begin? Location, where is the problem located? Duration, when does it start? How long does it last? What's the severity? What's the effect? What effect does it have on you? What's the pattern? What makes it worse, better? What are the associated factors that you think contribute to the problem? Cold spa, old carts, PQRSTU. Then you've got the patient's past personal history. And this includes things like what happened during their childhood and what's happening in their adulthood. Example questions could be, can you tell me how your mother told you about your birth? What diseases, if any, did you have as a kid? Measles, chickenpox, mumps. Did you have any immunisations that you're aware of? And are they up to date at present? Do you have any allergies? Past personal health history. Family history, very important. And this asks questions about the health of their parents, grandparents, siblings, and any children. And this identifies patients, victims, family members that may be at risk. Important familial conditions include things like high blood pressure, coronary artery disease, high cholesterol levels, stroke, cancer, hypothyroidism, diabetes mellitus, obesity, alcohol or drug addiction, mental health issues, and genetic conditions. Family health history. Then it's important to review the systems. And by reviewing the systems, this has a series of questions about all the body systems, whether it's skin, head, eyes, ears, nose, allergies, mouth, throat, neck, etc. And this relates questions while physically examining, and it provides information that identifies where issues could be problematic. Okay, that's the end of this presentation that revolves around health assessment. If you found that these are of any benefit, please recommend them to your colleagues, subscribe, and follow through with other Dr. Manny Learn Shops that revolve around health assessment. Thank you. God bless.